Thanks so much for having me, and for everyone for sticking around. I apologize in advance because there's no Barbie pictures in my slides today. Only disclosure I have is that I do have grant funding specifically on this topic, so if I seem like extra excited about it, that's why. I think the long and short of it is this: too long, don't read. There's actually not a lot of data in females with groin or with hernias in general, both for groin and ventral. And I think it's sort of due to historical problems that we've seen where females have been excluded from studies due to anatomic changes or worries about pregnancy and hormones. So a lot of the data that we have is sort of based on small studies or observational data. What we do know is that in general, females have worse outcomes after hernia repair, both for ventral and groin. This is a figure from one of the studies we did looking at just 30-day complications after ventral hernia. And you can see that females had not only a higher risk of complications overall, but the risk increased with increasing hernia size, where for males, that risk of 30-day complications was static. And we don't really know why this is. I think that's where a lot of the work needs to be done. But we also know that in addition to more surgical complications, females are more likely to experience chronic pain, decision regret, and recurrent hernia. And I would argue that this is for two main reasons. One, as I mentioned, there's a real lack of high quality evidence in this space. But even where there is, I think there's a lack of sex-specific treatment. So a lot of the things that Dr. Collins was just talking about, surgeons are either unaware of or not really implementing in their practice overall. So to start with groin hernia, I'll go through this for both groin and ventral, but this is a slide that I love to show, just looking at some of the seminal studies that have been done looking at watchful waiting and surgical approach. And you can see that almost no females have been included in these studies. None of them were included in watchful waiting studies, I think due to that risk of femoral hernia, which we now know is actually not even as high as we may think it is, only 15 or 20%. But even for surgical approach, women have really been systematically excluded from this. But there are some recommendations. So when we look at the most recent guidelines from 2018, which they did re-update these guidelines, but I don't think they updated the guidelines for females. But in general, we recommend timely elective repair. So avoid watchful waiting, unlike male patients where you can say for a minimally symptomatic hernia, we can safely watch. We don't have that data for females. And that when you are going to repair a hernia, you should consider a minimally invasive technique if available and appropriate for the patient, again, just given this risk of femoral hernia. The watchful waiting, again, we have no data on this. And when you look at the guidelines from 2018, the rationale behind that is that since strangulation risk is unacceptably high, timely elective repair is strongly advised, but we have no systematic reviews. Interestingly, when you look back to the original studies that were done for male patients, this was the exact same rationale, was that we didn't have data, there's such a high risk of incarceration that we really need to fix them all. And we now know that not to be true. So I would argue that we do need prospective trials. I think, I'm really excited about doing these studies in the future, and females would actually participate. This is some data that was presented actually by one of my medical students earlier this week of a qualitative study where we asked females what was their experience. A lot of the same things we've already heard, that, misdiagnosis, delayed diagnosis. But when we asked people if they would participate in a study, you can see almost half of them said that they would be willing to be randomly assigned to surgery versus watchful waiting, and many more than that would be willing to serve as an advisor. So I think really exciting and a lot of work ahead of us. But what about surgical approach? So we do have a little bit more data there. We know this is a study that we did in Medicare, but it's been shown in a lot of the European registries as well that using an MIS approach is superior for females. Again, we think because you're more likely to detect a femoral hernia, and it may have some benefits in terms of chronic pain. But when we look across populations, most female patients do not get a minimally invasive repair. So these are two studies we did. One was looking just in the state of Michigan, one more broadly in Medicare, and we can see that the majority of females undergo open hernia repair. Some of this you can say, well, it might be due to those guidelines, like we didn't have those guidelines yet, or maybe minimally invasive repair is not available. But what's interesting is that in both of these studies, male patients more often underwent an MIS repair. So kind of interesting that not only are we not following the guidelines, but doing it in sort of the worst direction than we would expect. Looking at ventral hernia, we again have some recommendations, probably not based on randomized controlled data, but the main recommendations are, if you can, to postpone a ventral hernia repair until completion of childbearing. And that's based on studies such as the figure shown here, where we see that increased risk of operative recurrence with increased parity, so not surprisingly. But when you do need to repair a hernia in a person of childbearing age, perhaps consider avoiding mesh if you can. Again, we know that there are circumstances where this may not be true, but these are sort of the general guidelines. Again, are these guidelines being followed? And we don't really think they are. So this was a study we did looking again in the state of Michigan. We looked at females of childbearing age, which depending on where you look is up to about age 45, and found that the majority, or about 2/3 of patients, did receive mesh. And you could say, there may have been some shared decision-making going on. This may be appropriate. And while I agree, I think what we would expect, though, is that you'd see perhaps a lower use of mesh in this younger population that's perhaps more likely to still be in their childbearing or their planned childbearing phase of their life versus person in this older cohort. And again, I think that's probably because surgeons maybe don't consider these things as much, and we've found that to be true. So these are quotes from a qualitative study where surgeons were asked about different management principles for abdominal wall hernia, and they basically said, I don't think about it. So this participant said, you can't get a promise from someone that they'll never get pregnant again any more than you can get a promise from someone that they won't get fat. You operate on them the way they are. If you get pregnant and or fat, your hernia repair might blow out, but I don't change the approach because they might. They might not. So basically saying, sure, these recommendations or guidelines are there, but it really doesn't impact my practice at all. So how can we get better for this? I think, as I hope I've hammered home, we need a lot more prospective studies. But as we know, a lot of those trials take a lot of time, funding, effort. So I think in the meantime, attention to equity when we're thinking about observational studies, development of guidelines, but also thinking about when we do have data, how do we present it to surgeons and patients in a way that's more likely to lead to practice change? Thanks so much.